We've heard so much about the dramatic advancements in the treatment of TTR amyloidosis, and one of the barriers to accessing these agents are their cost, and that really can only be borne not by the individual but in an insurance consortium. And some of you may know that there are barriers to access these agents and sometimes combinations of agents. A regular speaker at this conference is Ms. Bryant, who's a cancer rights attorney and the chief operating officer of Triage Cancer, who'll be addressing a little bit about insurance and how that applies to acquisition of these new agents. She's also going to be chairing a breakout session at 3 o'clock where if you have specific questions with regard to coverage or what you might consider doing in order to acquire coverage, she'll be available for those questions. So welcome back and thank you.
Well, good afternoon. How are you all doing? I will tell you up front that Muriel is the only human on the planet that could get me to agree to talk about health insurance in 20 minutes or less. But what Muriel asks happens. So I'm actually delighted to be here today. As was mentioned, my name is Monica Bryant. I'm a cancer rights attorney and chief operating officer for an organization called Triage Cancer. What we do at Triage Cancer is provide free education on all of the legal and practical issues that come up after a serious medical diagnosis like cancer. And we've been doing this for many, many years, and really what came out of this was that none of this is unique to cancer. It's really relevant information for anyone trying to navigate the healthcare system. And so we've recently launched a program that we're calling Triage Health that provides all of the same information, but without the word cancer. So I'm going to certainly point you to resources that we have on our website, and you are welcome to use them and spread them throughout your communities, even if they aren't related to cancer. Now, as was mentioned, we can have all of the fantastic treatments that could possibly exist in the world, but if people can't afford them to access them, they're really not helpful treatments. And health insurance is an unfortunate reality in our system. It's incredibly confusing. But even with health insurance, we know that people are still experiencing medical debt. And that's for a number of different reasons. But primarily what we find is that people who are experiencing medical debt, who have health insurance, typically don't have the right health insurance policy for them, or they don't know how to navigate the policy they have. It's confusing. Given that health insurance is the #1 most significant contributing factor to financial burden after serious medical diagnosis, and that it could literally be a decision that costs tens of thousands of dollars if you make the wrong one, how much time do you think Americans actually spend on picking their health insurance policy? Any guesses? 6 hours? An hour? Well, I'll tell you what. When we look at what the time it takes for people to make serious purchase decisions like buying a television or a car or a computer or a vacation, it's in the hours, certainly. Health insurance, 15 minutes or less. That is terrifying. Now, the good news, because I don't like to always be negative, is that we actually now have the opportunity to make health insurance decisions every single year. And certainly we should be making these new decisions anytime we have a life-changing event, like changing jobs or leaving a job, if we are moving or there's a relationship change, like a marriage or a divorce. But even absent all of those big things, every single year, every single one of us needs to be spending more than 15 minutes making our health insurance choices. And so that is the good news, that this is very timely, because we are in the period of time of the year where almost everybody gets to make their choices for next year. The specifics are going to depend on the type of insurance that you have. So if you have insurance through an employer, you do have to check with your employer because it could be any time during the year, but many employers pick a fall period. Medicaid applications are accepted year-round. As soon as someone meets the income and other eligibility requirements, they can submit an application. Medicare's open enrollment period is right now until December 7th. And if you are purchasing your own insurance, perhaps through the state health insurance marketplaces, we are about to start open enrollment on November 1st. Now, this is an incredibly important time of year, and as was mentioned, I will be in a breakout session later today if you want to come and ask specifics about your situation. But also know that if you have one of those life-changing events where you're going to lose coverage or something else has changed, there are special enrollment periods into every type of coverage. So these decisions aren't just left till the end of the year if you experience a change mid-year. And given that I only have 20 minutes, I am going to point you back to some resources that exist on our website for options that you might have if you're losing your employer-sponsored insurance, if you are potentially trying to re-enter the workforce, or if you are switching to another type of coverage. But one thing I wanted to make sure I was able to talk about today while I had all of you is Medicare. For those of you that aren't familiar, Medicare is a federally run health insurance program for individuals over the age of 65 or people who have been receiving Social Security disability insurance for 2 or more years. When we talk about Medicare, it is often talked about as if it is one thing, when in reality, it is 4 different things at a minimum. Medicare is divided up into different parts. So Part A is hospital insurance. It's going to cover when you are inpatient somewhere. Typically, if you've worked and paid into the system, Medicare Part A is premium free. But that doesn't mean there aren't costs associated with Medicare if you are inpatient somewhere. Medicare Part B is your medical insurance. It's going to cover doctor's visits and immunizations. Often IV treatments are covered under Part B. Even if you've worked and paid into the system, there is a monthly premium that you have to pay for Part B. There's also an annual deductible and a co-insurance. So you have to pay 20% of your Part B costs throughout the entire year. And there's no out-of-pocket maximum. So there's a big unknown that comes with Part B because you just don't know at the beginning of the year what all of your treatments are going to cost. So A is hospital, B is medical, D is prescription drug coverage. Prescription drug coverage has only existed since 2003, so it really isn't that old. Part D plans are sold by private insurance companies, so the costs are going to vary from plan to plan. The coverage is also pretty confusing. So here's how Part D coverage works. First, someone has to pay their deductible, which my eyes are so bad and I can never remember the numbers. But I believe it's $505 for this year. You have to pay that out of pocket. Once you've paid your $505, then you enter the initial coverage phase. And this is where you would pay 25% of your prescription drug costs, and Medicare would pick up 75%. Until you've gotten to a total of $7,400 out of pocket, then you enter what's called the catastrophic coverage phase. And this is where Medicare picks up 95% and you're responsible for 5% or a nominal dollar figure. But in the drugs we're all talking about today, it is likely going to be that 5%. There is also no out-of-pocket maximum with Part D. So you continue to pay that 5% for the rest of the year. And 5% of a lot of money is a lot of money. I'm a lawyer, I don't do math. So it's obviously been a significant challenge for people who have high prescription drug costs, because think about who is receiving Medicare. It's seniors who often have fixed incomes and people with disabilities so severe they cannot work. Those individuals often don't have unlimited income to pay for their prescription drugs. So the good news is a law was passed recently called the Inflation Reduction Act. And this law did a whole bunch of different things, but specifically related to Part D coverage, it did some really valuable things. And these things are going to be phased in over time. So the first thing it did was, starting next year, it's eliminating that 5% catastrophic coverage, which essentially means that there is now going to be an out-of-pocket maximum for Part D. Now, the exact dollar figure is going to depend on your Part D plan, and we don't even have the maximum that it's going to be for next year, but it's going to be about $8,000. Now, $8,000 is still a lot of money. I'm not saying it isn't, but when we think about $8,000 versus the unknowns, this is definitely a step in the right direction. And then in 2025, we go one step further, and there is now going to be an out-of-pocket maximum of $2,000. That is significant. The other interesting thing that's happening in 2025, in addition to the $2,000 out-of-pocket maximum, there's going to be something called cost smoothing. And what that does is it allows someone who is on a very expensive prescription drug to spread out their expenses throughout the year. So some of you may reach that $2,000 cap in January. And so you don't have to pay all $2,000, you get to spread it out over 12 months. We are still waiting for final regulations from the government on exactly how this is going to work and be implemented, but it is something to keep an eye out for, and certainly when we get that information, it's something that we'll be putting on our blog at Triage Cancer, so you can certainly access it there. So A is hospital insurance, B is medical insurance, D is prescription drugs. Someone could essentially have 3 different premiums, 3 different deductibles, 3 different cost shares. It's a lot. An alternative can be found in Part C, and these are Medicare Advantage plans. These are plans sold by private insurance companies that bundle all of the services you would get under Parts A and Parts B, and most also include prescription drug coverage. Now, in addition to bundling and making it sort of administratively easier, Part C plans also have an out-of-pocket maximum. And for this year, that out-of-pocket maximum is $8,300. So when we are talking about the difference between A, B, and D, which is often referred to as original Medicare and Medicare Advantage, the 2 major things to keep in mind is with A and B, original Medicare, that's fee for service, which means you can go to any provider around the country that accepts Medicare and be covered. With Part C, it's managed care, which means you have a network of providers that you have to stay in. And where this starts to be a little bit of a challenge for people is they might pick an Advantage plan because on its surface it seems less expensive. But then they get diagnosed with a serious illness and they want to go see the expert in that illness. And that expert accepts Medicare, but isn't in the Advantage plan's network. And so in that situation, that person is going to be limited in the providers that they can see. Pros and cons to everything. The other thing is you are probably, if you watch television with commercials, seeing the ads for get your free Medicare plan. Yeah, they lie. Those are not free. You still have to pay at least your Part B monthly premium for your Advantage plans. It just means they're not charging you anything above and beyond that. So frankly, if you ask me, I think it's deceptive advertising that they're calling them free because they're not actually free. You still do have to pay for something. So let's say you're in a situation where you want the freedom of being able to go to any provider around the country, but those unknown out-of-pocket expenses for Parts A and B are scary. The thing that you can do to protect yourself is to purchase an additional policy called a Medigap plan, also sometimes referred to as supplemental plans. And these are an additional plan that you purchase that pick up the out-of-pocket expenses that come with A and B. Now, these are identified by letters A through N, not to be confused with Medicare Parts A through D. because we like to keep it simple. So here's how this all works if you're picking or you're trying to make Medicare decisions. You get to drive in one of two lanes. The first lane is Original Medicare, where you pick up Part A for your hospital insurance, Part B for your medical insurance. You decide if you want prescription drug coverage. I hope the answer is yes. And you buy a standalone Part D from a private insurance company. Then you can say, I want to protect myself from the unknown expenses with A and B, and I'm going to purchase a Medigap plan, also known as a Medicare supplemental. That's lane one, and lane one allows you to go to any doctor around the country that accepts Medicare. Lane two is a Medicare Advantage plan, otherwise known as Part C, where you now have a managed care plan that has a network of providers you have to stay in, but it's going to bundle all of the services you would get under Parts A and Parts B. If you pick one of the 10% of plans that does not include prescription drug coverage, you can go pick up a standalone Part D. But that's where your options end in lane two. And the reason for that, the reason you can't get a Medigap plan in lane two, is because lane two comes with the out-of-pocket maximum. So, when you are shopping for health insurance, regardless of where you get your insurance, whether it's through an employer or through a government policy like Medicare or Medicaid, or you've gone and purchased your own insurance, you have to not just be looking at that monthly premium when making decisions, because that really only shows us a very small piece of the puzzle. We also need to be looking at the total cost it's going to cost us for the year in a worst case scenario, and to make sure that absent Original Medicare, we've picked a plan that includes our providers. And that's not just your doctor. That's labs and imaging centers and hospitals, and if you're getting surgery, the surgical center. And then, of course, you're going to want to check the prescription drug coverage before you pick a plan. Because don't assume that all of your medications are going to be included on every plan's list of covered drugs. Now, I just explained a very complicated system to you in 10 minutes or less. So I just want to remind you, we have tons of resources for free on our website. There are short animated videos. There's a 90-minute webinar we just recorded last month if you really want to do a deep dive and learn more. We have printed materials. Everything is available in English and Spanish. We also have a tool called our comparison worksheet. We have this tool for Medicare to be able to compare two or more Medicare plans. We also have a tool to do the same thing for employer-sponsored and individual plans. It's something that can just be printed straight off our website, and it walks you through how to do the math to figure out exactly how much your plan is going to cost you. But getting the right plan is really only half the battle, because the reality is the system is often set up to deny you. Little preaching to the choir here today, right? What I want you to walk away from today is that you don't have to take no for an answer. In every type of health insurance that is comprehensive coverage, there is at least 2 opportunities to appeal those denials. In Medicare, there's 5. So this is absolutely an added burden on all of you when you are already dealing with more than you should have to. I fully admit that, but it is almost always worth the effort. We know that of the people who go to the second level of appeal, the external appeal, somewhere between 40 and 60% of those are decided in favor of the patient. So about half the time, when the insurance company says no, they're getting it wrong. Unfortunately, though, people aren't using the appeals process. We know that 99.9% of all the denied claims aren't appealed. 99.9% are never appealed. Yet, half the time when the insurance company is saying no, they're getting it wrong. So when we're talking about access to care and financial health, this appeals process is an incredibly valuable tool. I will also say that I really just scratched the surface of all the things that are legal about healthcare. And so if you are interested in any of these things, including employment rights, staying at work, leaving jobs, disability insurance, we have resources on all of those things that you can certainly feel free to avail yourself of. And I also know there are multiple breakout sessions this afternoon that you may be interested in attending. If you aren't able to come to mine and get your questions answered, there is another opportunity. Through our legal and financial navigation program, you can go to our website, fill out a form, you'll get an email with a link to schedule a call with us. We get on the phone, we try to answer your questions. So we don't provide legal representation, we don't enter into that kind of relationship, but we will try to give you the information you need and answer your questions. So I won't be hurt if you don't come to my breakout. And this is just the contact information for Triage Cancer. And I know we're running behind, so should we save questions to the breakout?
Questions. Thank you.
Thank you very much.